welcome, and it is my pleasure today to introduce Naomi Fujioka, who will give the seminar this morning. Naomi is a Minnesota native. She has got her bachelor's degree in piano performance at the University of Minnesota. She also did pre-med. Then she went to medical school and has done her residency and become faculty member here. She also has an MS in clinical research from the University of Minnesota School of Public Health. Naomi is a physician scientist. She not only is a clinical oncologist, but she oversees a number of clinical trials, and she is a well sought after clinical collaborator for members in the carcinogenesis and chemoprevention program. She's collaborated with Steve Hex, Fakadu Kasi, and Chris Zing before he left, and maybe still continues. And today she's going to, and I wanted to also mention that she has been recognized as a rising star by the Minneapolis too many pieces of paper here, and I didn't get it, by the Minneapolis St. Paul magazine. So she's recognized for her clinical efforts as well. So today she's going to talk about her work in chemoprevention. Thank you, Naomi.
Thank you so much. So excited to be here. I actually haven't given a talk for a few years, so it's really exciting to talk about the work that we've been doing over the last few years. So one of my favorite books growing up was Lord of the Rings and The Hobbit, and so I like to make analogies and keep it fun and light. So I thought, my research career has been more or less a road, and it's taken a lot of windy paths, and here we are. So let's get started. All right, so a little bit of an outline to talk a little bit about background, because when I was preparing this talk, I actually started to realize that not everybody knows what I'm going to be talking about. And I'll talk about the work that we've done so far and what I'm hoping to do in the future, and then we'll come back home. So what is chemoprevention? Because until I met Dr. Hecht, I actually didn't know what chemoprevention really was. So I thought I would start out with a pretty classic definition of cancer chemoprevention. And it's a misnomer, especially if you're an oncologist and you see the word chemo, you think about chemotherapy, but that is a misnomer. So chemoprevention is really just using any compound, drug, food, whatever you can think of, more or less, to prevent, reverse, suppress cancer from developing. And I study cruciferous vegetables, so just like chemoprevention, when I first started all this, I didn't really know what cruciferous vegetables really were. So here's a smattering of cruciferous vegetables, and so things like cabbage and bok choy and arugula, broccoli, watercress, Brussels sprouts, things that have become near and dear to me over the last 9 years. And specifically within cruciferous vegetables, we study vegetables that come from the genus Brassica. So again, cabbage, let's see what else is there, Brussels sprouts, of course, broccoli and watercress are examples of Brassica vegetables. And so why is this interesting? So it starts with epidemiologic data, and there's a wealth of information out there, and this is just one example. So it turns out that there's an inverse relationship between amount of cruciferous vegetable intake, and in this case, for example, lung cancer risk. And that's been shown in a number of cancers. It's also stayed true when you control for things like smoking, which is shown here. And the problem is that the epidemiologic data is not consistent. So some studies showed a protective effect of cruciferous vegetable consumption, and others didn't. And we're going to talk about why that might be in a little bit. So what's in these vegetables to make them special? So they contain chemicals called glucosinolates. And these are naturally occurring chemicals that the plants possess to actually protect themselves against invaders and disease. They're derived from amino acids, and there's two major categories. The first is isothiocyanates. So a lot of you work with something called PEITC, for example. And the second class is indolyl glucosinolates, and that's the one that we're going to focus on today. There are actually 6 of them. 4 are found in vegetables, and then 2 are found in abundance, and those are glucobrastin and neoglucobrastin. And the next table is a study done here by Steve Heck's group showing the relative concentration of the different glucosinolates in a variety of common vegetables. And so glucobrastin is there on the top row. And you can see that the concentration is quite high relative to the other glucosinolates. And it's important to note that the concentration of and proportion of glucosinolates can vary based on a number of factors, so things like growing conditions. So it's interesting because, you know, if you're doing a therapeutic cancer clinical trial, you don't have to think about how the vegetables were grown and what kind of soil conditions and how many days it rained and what kind of fertilizer and all that stuff. But we actually do have to think about that. And it's important because that can influence the proportion and concentration of the chemicals. So it turns out that glucosinolates are inert, and they require the action of myrosinase, which is an enzyme in the plant, but physically segregated from the glucosinolate. And so the idea is when the plant's cells are damaged, for example, if you chew them up or chop them up or they get tromped on, the myrosinase is released, and then it comes into physical contact with the inert glucosinolate, and then it turns into an isothiocyanate, which is the bioactive compound. And in the case of glucobrastin, it turns into indole-3-carbinol. And it turns out that this is really important, and it's been central to the work that I've been doing and we've been doing here for the last number of years. In vivo, indole-3-carbinol undergoes oligomerization. And so in the acidic conditions of the stomach, for example, it turns into dimers and trimers and higher order oligomers, whereby higher pH favors higher order oligomers. And the most important of these is diindolyl methane, or DIM. So it turns out this guy's pretty important too. And relevant to the work that we're doing here, so this is work done by Ficado Cassi in the lab, and this is just a very small fraction of the wealth of data out there. But the idea is that indole-3-carbinol and DIM can decrease lung tumor formation, lung tumors induced by tobacco carcinogens. In this case, benzoylpyrene and NK, and I'll explain what those are in a little bit. And so you can see in the table here, both indole-3-carbinol and DIM can reduce tumor multiplicity by, quite substantially. And this also held true when the indole-3-carbinol, for example, was given after carcinogen administration, which is important because in real life that might mimic somebody who's quit smoking and then realizes there might be something they could do to reduce their chance of developing tobacco-related lung cancer, because we all know that even after smoking cessation, the risk still remains. And it turns out, you know, in my practice, for example, a lot of people actually quit smoking a number of years ago, and they're coming to see me with lung cancer 10, 15 years after they quit. So this is important. And here you can see with indole-3-carbinol, the tumor multiplicity in this mouse model was reduced 74%. And again, this is just a very, very, very tiny fraction of the wealth of data that's out there supporting the potential chemopreventive effect of these compounds, and as well as mechanistic data to show why and how it might be working. So my job is to think about how you might study this in people, which is a very different ball game as in other fields. And so some of the questions that come to mind is, and for example, one of the problems with epidemiologic data is, until recently, there really was no objective biomarker to say how much glucosinolate or indole-3-carbinol, et cetera, was a person taking up. And you can't, because of all the variables that go into uptake and absorption and metabolism, you can't just look at how much people are eating. So the first question was, can you objectively quantify how much people are taking up? And then the second question, for example, could be, is it better to eat the food, or is it better to take supplements of these individual phytonutrients? And how do people metabolize these things, and how much is too much, how much is enough, and what else might influence how these things are working in people? So these are all questions that had not been answered adequately until hopefully recently. So I want to take a step back, and so one of the first major questions is, why would you study food instead of studying supplements? And there's a number of reasons, but some of them I've listed here. And when I was going through medical school, people oftentimes were looking for a pill to fix something. And I will say that culture is changing very rapidly and quite dramatically, but the idea is that there is no such thing as a pill that fixes everything. And even now, I think it's more important to emphasize that a change in lifestyle is the best medicine as opposed to a pill. So that's one reason to support using a food-based intervention compared to individual nutrients. When you think about cancer incidence and the burden of cancer on a global level, there's no question that in this country, it's not a problem really to get supplements for the most part. They are generally going to be affordable, even though some can be fairly expensive. They're going to be, people will have access to them. But globally, that's certainly not the case. So accessibility, affordability, and sustainability are three very important reasons why food-based intervention might be more useful and sustainable than a supplement-based intervention. And on top of that, it's not clear at all that more of the nutrient is going to be better. And I'm hoping to show some data that supports that. And there's lots of other reasons, but these are some of the main ones that come to mind. And so, because we're all scientists here, when you see these problems, you start systematically plugging away to try to whittle down the answers. And so I'm going to talk about 4 steps that we're taking here to try to answer some of these questions. And the first one is to develop a marker to objectively quantify the uptake of the beneficial phytonutrients in these vegetables so that we can quantify the exposure and then start to figure out what it's doing to people. And concurrently, the second step is to figure out, can we differentiate between high exposure and low exposure? And then the third step is to see if we can start at a low dose and work our way up, and what does that do in people. And the last step that I'll talk about a little bit today is seeing what kind of effect these vegetables might have on people. So again, the first 2 steps we did concurrently, and the first one is to develop a urinary biomarker to measure urinary DIM, and I'll explain why DIM and not indole-3-carbinol in a second. And the second step is to differentiate between high and low exposure to glucobraskin. And I'm going to go a little bit in reverse order from what we did actually in real life, because we did a study, and then we got the urine specimens from that study, and then used that in addition to previous specimens to develop the biomarker. But I'm going to talk about developing the biomarker first. And so the first question is, why would we use DIM instead of indole-3-carbinol? So this is prior work done by a guy named Gregory Reed. And he basically took his indole-3-carbinol supplements, gave a single dose to people. And you can see the doses here on the left. These are in milligrams. And tried to measure indole-3-carbinol in the blood, and also measured DIM. And what they found is that they could not detect indole-3-carbinol in the blood. And the first time point that they took a sample after the administration of the supplement was 60 minutes. So within 60 minutes, there really was no indole-3-carbinol detectable in the blood. What this study also shows, though, is important data to figure out how we might design the studies that we did. And so they saw that there was no significant bioaccumulation. They actually had a part of the study where they gave people 400 milligrams twice a day for, I think, 4 weeks, and then did the same sort of pharmacokinetic analysis on these people. And also, if you give more, it doesn't mean, it didn't translate into producing more urinary dim. And so that's important, and that's shown here in this figure. So I know it's not possible to see the actual doses, but the idea is that if you gave 1,000 milligrams, you saw a certain amount of dim in the blood, and then if you gave 1,200 milligrams, it looks like it's more, but it actually didn't turn out to be any more dim in the blood. So that suggests that there's a maximally biologically rational dose. And they also used DIM, did the same sort of study, and got the same sort of information. So that was really helpful in terms of designing the studies that we did. And so going back, you develop the biomarker of measuring DIM in the urine, and it sounds really straightforward. You take some beta-glucuronidase, and then and what I learned about mass spec, and I still don't know a whole lot about mass spec, truthfully, but the internal standard is very important. So if you can't buy an internal standard, you make it. And obviously it's a lot of work that goes into that, but the internal standard was made here. And it turns out it really didn't work very well at all. And Pramod and Cheryl, who was, I think she was doing her postdoc or her PhD, spent countless hours on trying to figure out why. And I even remember Pramod sending me an email about tryptophan because, again, glucosinolates are derived from amino acids, and so indole 3-carbinol is in part derived from tryptophan. And so he sends me an email and says, we got to figure out if these people ate tryptophan, because what was happening is all the baseline samples, and I know I haven't explained how we did the study, but the idea is that people in the study didn't eat any cruciferous vegetables, so they shouldn't have any DIM in the urine, right? But they did prior to intervention, and couldn't figure out why that would be. So I remember looking through all the food diaries that we had taken and figuring out who ate turkey, and then Googling what kind of foods had tryptophan, and we kind of basically made a food frequency count, and then one of the statisticians who's now in urology was doing statistical analysis, and needless to say, there was no correlation between tryptophan intake and why we were finding urinary DIM in the baseline samples. But it turns out that the beta-glucuronidase that was initially used was derived from snails. And then it turns out that snails eat vegetables. And I would have really loved to be in the lab when you guys figured all that out, but in any case, I thought, oh my gosh, this is crazy. So it turns out that the DIM that was being detected in the urine in the baseline samples were, theoretically there shouldn't have been DIM, was probably coming from the snails. And so if you take beta-glucuronidase that's derived from E. coli, you didn't see the DIM in the baseline samples. So below, here on the right side, you see the mass spec tracing. So here's the standard. So you see the D2 DIM. And then here's the urine spiked with, or where they use the beta-glucuronidase derived from snails, and you see DIM in the sample. And if you use the E. coli derived beta-glucuronidase, you do not see DIM. So in those two slides was probably at least a year's worth of work and a lot of hair pulling and that sort of thing. But I thought it was amazing that they figured it out. So here's how you prep the urine. You take a ml of urine and you use the E. coli-derived beta-glucuronidase, really important. And over the time, the method's been refined, but this is it more or less. And again, I'm not a chemist. I was a pianist, and then I was a liberal arts major, and I just like to show this slide because I think it's kind of funny. This is a description in one of the manuscripts of the mass spec part of things, and I got to tell you, it took me a long time to figure out what all that meant, and I will leave it up to the experts. But so the bottom line is it's very complicated. It's very precise. There's a lot of work that goes into refining these methodologies. This is just a representative example of some tracings for those of you who are involved in mass spec. Very clean tracings, and the idea is Again, I'll show you the study design and everything like that in a second here, but after eating the sprouts, here's the bottom row is the standard, and then the top row is the subject specimen. So that got all worked out. So here's the study design. So sorry to go a little bit backwards, but so in the first study, and again, this is differentiating between high glucobraskin exposure and low. We had 25 people abstain from cruciferous vegetables, and then they got randomized to consume either Drake Cross Brussels sprouts, 50 grams once a day for 3 days in a row, or Blue Dynasty cabbage, 50 grams once a day for 3 days in a row. And these vegetables or cultivars were chosen because of their relative glucobraskin concentrations. And the idea here is that J. Cross Brussels sprouts contain a relatively high amount of glucobraskin, and Blue Dynasty cabbage contains a relatively low amount. We actually measured the amounts, and I'll show you that data in a second here. So they consume the vegetables once a day raw, because it actually turns out that if you cook the vegetables, it deactivates myrosinase, so you don't get the conversion or good conversion into Nil-3-carbinol. So consume them raw once a day for 3 days. And after each vegetable feeding session, we collected all the urine for 24 hours. The people went through a washout period of 5 days. And again, based on the prior work using supplements, we knew that the washout period could be relatively short. And in any case, they switched to the other vegetable, the one they hadn't eaten in the first place. And they consumed that vegetable for 3 days, once a day for 3 days. And so basically the idea is in this kind of study, each person acts as their own control or comparison. Like I mentioned before, the growing conditions are very important in terms of the glucobraskin concentration that can result. So we actually collaborate with a horticulturist who grew the vegetables for us. And I wish we had actually a photograph of the vegetables when we all went down to Waseca, but couldn't find it. So, but anyways, they were grown for us, and both in Waseca and then in Rosemount. And this is just to show the kind of conditions that you have to think about when you're growing these vegetables and doing it consistently from year to year. And I also want to point out that for sprouts, it takes about 98 days from planting to harvest, and cabbage, it takes about 65 days. At least this year, particular year, it took that much time. And previous work showed that if you store the vegetables under certain conditions, humidity, temperature, and in these particular plastic bags, the glucobraskin concentration can be maintained for actually months. And here's the results of the glucobraskin analysis in the vegetables. So the cabbage, like I said before, has a relatively low amount. And just to show that it didn't change over the course of the study, which I think we took about a month or 6 weeks to complete the whole study, get everyone through. We actually herded everybody through at the same time. So we took samples at various time points throughout the study, but the mean was pretty close to the initial concentration for both cabbage and Brussels sprouts, and you can see that Brussels sprouts has a lot more glucobraskin than the cabbage. Here's the subjects who went through the study, just a little bit of demographic information. And these were all healthy people who were not smokers at the time of the study. And here's the main result that we saw. So indeed, you can actually tell who ate cabbage and who ate Brussels sprouts. That's the bottom line. So the mean DIM concentration in the urine after cabbage was 0.4 picomoles per milligram of creatinine, or 681 picomoles per 24-hour urine collection. And after the sprouts, the mean was 9.05 picomoles per milligram of creatinine after sprouts, and then almost 15,000 picomoles per 24-hour urine collection. And what we were looking at as a primary endpoint in this study was the mean difference, and that turned out to be statistically significant. The other piece of information that was helpful was how much DIM comes out, how much do you pee out after you eat these vegetables, and it turns out very, very little of the original glucobraskin dose. And from primarily mouse and other animal studies, most of the DIM is excreted in the stool. But we were not in the business of collecting stool samples quite yet. So, So the conclusions for this first study and this first step was, yes, we were able to successfully quantify urinary DIM after people ate vegetables. And it was actually the first study to show that you can differentiate between high glucobrascolene exposure consistently and low. The method of quantifying the urinary DIM was obviously much, much better than it had been. We also, I didn't show this data, but there were significant individual differences. There was no period or carryover effects, and there was no bioaccumulation. So all this information is really helpful in terms of how to design the next study. So of the 4 steps, now we're on step 3. So the step 3 is refining how this biomarker might be used. And so what we thought we would do is look at a range of glucobrascolene, you can call them doses, and see how the urinary biomarker performed. And I call this a dose escalation study, but it was pointed out to me by pharmacologists that this is not technically, it didn't technically fit the definition of a dose escalation study, but it was a useful way to describe it. So the idea here is, could we use this urinary DIM biomarker to describe a wide range of doses after people ate vegetables? And when I was thinking about it, just like in the supplement study, I thought there's got to be a plateau. This is a big if. And if that's the case, where would that happen? Thirdly, I wanted to start thinking about what it meant that there was such large inter-individual differences between people in terms of how they metabolize the glucobrascolene. And that's nothing new to this work. It's been seen with any number of other phytonutrients and carcinogens. So in the study, we got healthy non-smokers. This time I said they shouldn't be vegetarians. They should be willing to abstain from cruciferous vegetables, and it turns out that's not hard at all. And we checked and made sure they had normal liver and kidney function, because liver and obviously these organs are very important in metabolism. Because gastric pH could affect how much indole-3 carbinol was converted into DIM versus higher order oligomers, we excluded people who were on basically acid reduction interventions. I myself am quite a Tums popper, so I was not eligible for the study. And then it turns out that antibiotics can wipe out gut microflora, obviously, and gut microflora is important in converting more indole-3 carbinol into DIM. So no recent antibiotics was an exclusion criteria or eligibility criteria. And then, it's not common to see this, but we thought we should exclude people who had issues with gastric absorption, people who had gastric bypass or had celiac sprue or those sorts of things. And in this study, we recruited, our accrual goal was 46 people, and we studied a total of 7 doses. And the doses you can see here, 25, ranging from 25 micromoles defined in terms of glucobrascolene, up to 500. And the numbers here are the number of people that we wanted to accrue to each dose. And to get a sense of the inter-individual variability, we studied more people in 3-dose cohorts. And to get a sense of how the urinary biomarker performed, we needed 4 people, at least 4 people per dose cohort. We again used J-cross Brussels sprouts and blue dynasty cabbage that were grown specifically for us. And this time, unlike the first study, I said, you got to eat it raw. No vinegar, no dressing, nothing. You can have a little salt. That's it. And water. And people had to be fasting, and I was going nuts. So what does this really look like? So 25 micromole of glucobrascolene in terms of cabbage. And, when you're looking at this low of a dose, you can't actually give any Brussels sprouts. So 75 grams of cabbage is not very much at all. It was very easy for these people to get through. After that, we started mixing up the cabbage and Brussels sprouts to get basically the salad that we gave to people. And I would say up to 300 micromoles, it was pretty doable. And about 400 micromoles, some people had a little bit of trouble. And I remember sitting in the study room where we were doing the study and watching these people eat, because we actually recorded how long it took for them to eat. And they had a little bit of trouble, but not too bad. But some of the people in the 500 micromole group had a lot of trouble. I think about 2 or 3 people just couldn't finish. And actually, even though it was a randomized assignment, I ended up assigning them to lower dose cohorts. And I think the longest was an hour and a half. It took the person an hour and a half. And I was just sitting there watching this guy eat, trying to get him through. It's like, you can do it. It is not easy. So to put it into perspective, what we did is we took the Brussels sprouts, we peeled off the kind of bad outer layers of leaves, and you don't want to do a lot of that because actually the highest concentrations are in the outer layers. And then we cut them in half, and that's how we gave them to people. So 500 micromoles of glucobrasine in terms of Brussels sprouts is roughly about a pint and a half. So 1 pint container. And remember, they're chopped in half, so there's a lot of air there. And then another half container. So yeah, it took a long time. It was not easy. And so the idea here is we obviously had a washout period. We collected a spot urine right before they ate the vegetables. These guys ate the vegetables once a day for 2 days at the study center, so we watched them eat, and then we collected urine. And in this study, I wanted to see if we could get away with shorter urine collections, because collecting 24-hour urines is not the easiest thing in the world, and there's always a chance you're going to miss pee collection, especially when you wake up in the morning. And so we divided up the urine collections into time periods of 0 to 2, 2 to 6, 6 to 12, and 12 to 24 hours. And actually, so Astia Roper-Botker was the coordinator who did most of the study. And by that time, I was still helping quite a lot. But she actually just sent me this picture yesterday, this photograph that she had taken yesterday. And this is kind of what it looks like. So I was always laughing because you go to college, and you go to 4 years of medical school, and 3 years of residency, and 3 years of fellowship, and I was in this room measuring pee. A lot of training to measure pee, but it's super important, and it was super fun. And there's actually a specific urine collection room with this huge, looks like a sink, but it's actually kind of a toilet. It's got a flush lever, and so there's specific SOPs you have to follow when you're dealing with pee. And then when you're done aliquoting and measuring and stuff, you dump the rest into this cool-looking toilet thing, and then you flush it. So, yeah, it was fun. Anyways, here's the subject. So we managed to get all 46 people through eventually. And this is what we found. So a couple of things. Indeed, there was a plateau. And so the x-axis in this figure is the doses. So here's 25 micromole and going all the way up to 500. And on the y-axis is the amount of DIM, and we log transform it because it's not uniform distribution. And so the dose does indeed, or the amount of urinary DIM does indeed go up to a certain point, and this correlates to the 200 micromolar dose of glucobrasine. So the idea is that anything beyond that doesn't actually produce more DIM. So that was really informative. And then we looked at the correlation. So what's the correlation between the dose that people consumed and the amount of DIM that they produced? And you could argue this isn't the most sophisticated analysis because, like I said before, there was a lot of inter-individual variation. But it turns out that at the very low doses, there's really very little. We couldn't find any correlation at all. At the 200 micromolar dose, it was pretty good correlation, 0.94. And at very high doses, there was, again, very little correlation, so 0.73. In terms of the kinetics, what we found is that the vast majority of urinary DIM is excreted in the first 12 hours. So up more than about 95% on each day. So that was really helpful. So it means that in future studies, maybe we could just collect urine for 12 hours instead of 24. Remarkably, though, I think we counted how many urine collections there actually were. So if there's, like 8 per person, and how many, collection periods is that? And we looked at the compliance, and I think only 4 people missed urination in this study. And it also talks about how we highly encourage compliance and how we get these people to really do what they're supposed to do. And we have all kinds of methods that Dorothy and her group have worked out, and a lot of coaching, a lot of phone calls, say how you doing. Please don't forget to collect your pee. The other weird thing is, we would give people these plastic bags to bring their urine back or carry it back and forth because, they kind of have to carry it everywhere they're going. And some people, especially students, they would just stick it in their backpack with their books, and I'd be like, oh, that's gross. But whatever works. Some people actually just carried it. They had no qualms about carrying it in public. They are opaque, so you can't see that there's urine in there, but you can tell they're jugs collecting something. The other trick that we use is we would have people close the toilet cover and put the jug on top of the toilet. So if they're going to go pee, they obviously will see the container. So there are all these tricks. And these are not things that you learn in school. So those are really fun. But anyways, from this study, we were able to conclude that, again, there's significant individual variability, but we knew that. The correlation is really not between urinary dim and glucobrasine dose is not that good at the extremes, but in the middle of the dose range, it's pretty good. And obviously, it's really difficult to eat a lot of raw Brussels sprouts. It's not realistic to continue this line of work in the future. Most of the urinary dim is excreted in the first 12 hours. And the thing that made me most excited probably was that more glucobrasine does not equal more dim. So what comes next? So then we start to see, well, what can it do in people? And this is a big what if. What I'm going to show you is incomplete data, but I'll give you a flavor of what we're seeing. But in order to see what kind of effect consuming cruciferous vegetables might have on people, we have to take a step back, and I'll give you a super quick crash course in tobacco and carcinogens. And so on the left is a figure showing carcinogens that are found in tobacco smoke. And nicotine is not a carcinogen, but is obviously found in cigarettes. But we have things like tobacco-specific nitrosamines, the most famous or infamous of which is N and K. We also have N and N, and these are only found in tobacco. Another important category is polycyclic aromatic hydrocarbons, or PAHs. And phenanthrene is shown here, but the prototypical PAH is benzoapyrene. And NNK and BAP are very well established, very potent carcinogens. And then we have volatile organic compounds, such as acrolein, benzene, etc. And the idea here is that people need to metabolically activate these carcinogens in order for them to become carcinogenic. And it turns out that people do this to varying efficiencies. And the hypothesis is that it may be, not everybody who smokes gets lung cancer. It's actually, for men, maybe just over, and somewhere between the 15 and 25% range, generally speaking, of heavy smokers. And so who are those people, and how do you figure out who they are? And how do you single them out? And it may have to do with how efficiently or inefficiently they metabolically activate these carcinogens, and or conversely, how well or inefficiently they detoxify these carcinogens. And that's been shown in case control studies, actually work done here, and is pretty well established in my mind. And central to the carcinogenicity of these carcinogens is the formation of DNA addicts, which is shown here. And the idea is that DNA addicts can cause irreversible DNA damage, and when you get them in a key tumor suppressor gene or oncogene, and the cell either doesn't die or doesn't fix it, then it can turn into cancer. So that's Crash Course Part A. Crash Course Part B has to do with polycyclic, focusing specifically on polycyclic aromatic hydrocarbons. And what's shown here is the pH phenanthrene, and its metabolism, metabolic activation, and detoxification mimics that of benzoapyrene pretty closely. And it's useful because you can't give a carcinogen to people. It's not ethical. But phenanthrene is generally not considered to be carcinogenic, so we could actually give it to people and use it as a tool to study metabolism of these chemicals or carcinogens. And because PAHs are not tobacco specific, you get a lot of contribution from environmental exposures. Virginia sitting right there, and his group developed a way to eliminate that confounding from environmental contribution to the pH exposure, and so you can deuterate phenanthrene. And so this is a tool that's been used over a number of years in a number of studies to study pH metabolism in people. So going back to how we started to look at the effect of these vegetables in people. So we designed a study, and it's still ongoing, I'll say. But the idea is we wanted to see if feeding people Brussels sprouts could have an effect on how people metabolize deuterated phenanthrene. And to do that, we're looking at the product of metabolic activation, which is phenanthrene tetrol. You can also, the secondary objective has to do with looking at the detoxification pathway, and you can actually look at the ratio and get information, between phenanthrene tetrol and phenanthrols, and get information about how it's being metabolized in people. And then I wanted to use this study as a platform to start looking at some highly exploratory correlative endpoints. So I wanted to see, I guess the first one's not that highly unusual to look at, but wanted to see if you are getting exposed to more or uptaking more of the glucobrasinin and the 3-carbinol, so you have more DIM in the urine. If you're one of those people, does that have more effect on decreasing metabolic activation, for example, of phenanthrene or not? And then I wanted to start looking at things like circulating immunophenotype and inflammation, and that's a very different aspect of this kind of work, but it comes from the idea that indole-3-carbinol, at least in vitro and even in vivo, can reduce inflammation. This is actually work that Fukado-Cassie has done here. So it's actually quite easy to collect the samples that we needed, so I wanted to get some preliminary data. So study eligibility criteria was very similar to the previous study. Because we're looking at things like inflammation and circulating immunophenotype, said no NSAIDs, no people on steroids are not eligible, things like that. Because the deuterated phenanthrene is actually in ethanol, you can't have people who are previously alcoholics and then people who are on medications like metronidazole and antabuse, and clinicians out there will know if you mix maybe even a ml of alcohol with these medications, you'll get really sick. And then I can't remember if it was the CPRC or the IRB, but they said we have to put this eligibility criteria into the protocol. I was like, oh, I should have thought of that. So this is how we designed the study, and it's really simple in concept. It's pre and post. So at baseline, you give people a microgram of deuterated phenanthrene. You collect a 6-hour urine. And previous work that showed that there's good correlation between a 6-hour urine collection period and a 24-hour urine collection period. And then you give them the Brussels sprouts once a day, so about 200 grams. So how much was that? That was a little less than a pint-sized container. Once a day for 7 days. And some of the feeding sessions we had at the study center, some of them they took home. And then halfway through, and then at the end, we collected 24-hour urines to look at DIM. And then on the final day of the intervention, after they ate the sprouts, we gave them a second dose of 1 microgram of deuterated phenanthrene, and again collected a 6-hour urine. And this is very preliminary data. It is not, we still really need to look at it very, very carefully. So on the x-axis is the subject number, and then the black bars represent the baseline deuterated phenanthrene tetrol level. So again, this is a product of metabolic activation. And then the gray bars represent the levels after the 7-day Brussels sprout intervention. And when you look at this, just glancing at it, it may not be that exciting. On the y-axis, I should point out, is deuterated phenanthrene tetrol level in terms of defined in terms of picomoles per mil of urine. But on a little bit closer examination, some subjects had pretty substantial reductions in deuterated phenanthrene tetrol. And for those of you who don't deal with this on a regular basis, I'll show you a different data set looking at a different unit. So it's important to note what the units are. So this is the other set of units. So it's probably more scientifically, it is more scientifically valid to look at the picomoles per the entire urine collection. The previous data set was also not corrected for milligram of creatinine, for example, which you would typically do. So when you look at it, when it's phenanthine tetrol levels defined in terms of picomoles per 6 hours, you see a bit of a decrease in a couple of subjects. And again, this is only 9 subjects, and our accrual goal was 42. So we still have a long ways to go in terms of completing the accrual. And this was the primary endpoint that I was looking for. I wanted to see a 30% reduction in as many people as possible. And looking at it further, start thinking about who are these people that had the little bit more substantial reduction. And the idea here is GSTT1 and GSTM1 are enzymes that are involved in metabolism of various things. And it turns out that maybe double nulls, so people who have no enzyme activity, first of all, might metabolize isothiocyanates less efficiently. So, they might hang around more in vivo. And so they might benefit more from the isothiocyanate exposure. Alternatively, when you're thinking about carcinogens, it may be that GSTT1 nulls have decreased tetrol levels, so decreased metabolic activation, whereas GSTM1 nulls might have increased tetrol activation. So it turns out this person actually was a GSTT1, GSTM1 null. This person who also had the 33% reduction, was actually intact. And again, the numbers are extremely small, to the point where it's questionable whether I should actually show you this data, but it's a hint, and it makes me think that it's definitely worthwhile completing the study. When you look at these people in terms of the absolute levels of the phenanthine tetrol, you can sort of say the GSTM1 nulls had relatively higher concentration or higher amounts compared to some of the other subjects who certainly had intact enzyme. But again, the numbers are very, very small. So it'll be exciting to see once we complete accrual what we find out. So that's the end of the data I'm going to show you. We're going to complete the study sometime this year. We are not going to any longer use vegetables, I think, grown by our horticulturalist collaborator, because we basically get a 2 to 3 month window where we can do these studies, and so it's really hard to get everyone through. And it turns out that we can actually probably go to a commercial source, and we have to still do this work to make sure that the glucobraskin concentration is pretty consistent. We have to develop a way to say that, measure the glucobraskin concentration in real time and adjust the quote-unquote dose of vegetables that we're giving people, but that's all, doable. And that's the next step in how we're going to complete the study. And then we'll look at some other urinary biomarkers of VOCs, for example. Like I said, I want to look at some markers of immunity and inflammation. And then from this sort of work and from the preclinical work, certainly that Ficado Cassie has done, we're actually starting up a phase 1 clinical trial looking at a combination of indole-3 carbinol and silbinin. And this will be a supplement-based trial, but the idea is that it's an exciting time for chemoprevention studies here. So I wanted to point out that the path to get here, from there to here, is really interesting. So we're all born, we all grow up, and this is me graduating from medical school. That's my mom. This is me graduating from residency. This is when I became a fellow. This is me finishing fellowship, and this is me being a goofball as a faculty member. And I never dreamed that I would be involved in chemoprevention research or tobacco carcinogen research. I do remember hearing about how you could paint coal tar on, was it mice or rats, on their backs and they get cancer and things like that. But I didn't know much. I obviously didn't know much about it, so it's really exciting. And even as of right here, right here, I thought I was actually going to be a lymphoma doc and be a transplanter. So there's a long story about how that changed. I knew nothing about lung cancer actually at the start of fellowship, it turns out. So it's amazing what happens, and if you look at all the people who have influenced our lives and how things take twists and turns here and there. And then I'm a big sucker for nostalgia and tradition. So we obviously have a huge tradition of chemoprevention here. And so that's Lee Wattenberg, and Michael Sporn is not here, but these are the fathers of chemoprevention. And so I really think it's important to look at the past, the present. So these are some people involved in chemoprevention work, and actually some people here know all these people. And I've met a handful of them. And for example, work with Dr. Andre. There's lots of other people who are heavily involved and contribute greatly to the field of chemoprevention. And then it's important to look to the future. So for those of you sitting out there, you know, where I was back in 1999. And I was just dreaming about getting to medical school and working in a lab and thinking, oh my God, what am I going to do? This could be you. So chemoprevention, what I want to say is chemoprevention is an extremely exciting field to work in. It's relatively new, and lots of opportunities. And it really has a huge impact. So, you know, as an oncologist, we think about, okay, can I develop a drug that can impact a lot of people, but and it's all really important, but if you think about prevention, you can theoretically impact millions of people. So that's my plug for getting into chemoprevention research. And then, lastly, there'll be a couple minutes for questions. I want to acknowledge a lot of people and thank, first and foremost, Steve Hecht. Still remember the first time I met you. And then everyone in his lab, and especially Pramod, and Steve Carmella, Cheryl, who's no longer here. I can't remember where she went. And then Ben Ransom, who I've been keeping in touch with, who just got into medical school and is going to start this fall. And also especially to Dorothy, and both Steve and Dorothy have given me tons of opportunities and helped me a lot. I want to especially thank Astia for doing the second vegetable eating study, and then Diane Rauch, who did the first one, and I worked with her on that one. She taught me the ropes. And then I want to thank also my colleagues, and I think, I know it seems kind of cheesy, but I really want to take this opportunity to thank my colleagues because they save me almost every day. So this is Manish Patel, who is another medical oncologist like me, and then this is Blake, who taught me everything I know in the lab when I was a fellow and listened to me whine all the time. And Bob Kratsky, who was my primary mentor during fellowship and suckered me into lung cancer, into the lung cancer field. And I always want to take every opportunity I can to thank Angela Mortari, who turns out gave me my first job in science when I was an undergrad and didn't know what a cytokine was, and I'd never pipetted before, and I still ask her, why did you give me a job, because I knew nothing. And then, of course, I want to thank my friends and family and my pets, who say hello to me every day. So with that, I'll end with a quote. Again, this is my favorite book, Life is a Journey, Research Careers Are Journeys. And with that, I'll take some questions.
Questions? Just a minute, Jill. That was a nice talk, Naomi.
Oh, thank you.
So if you have to eat these vegetables raw to get these effects, then how can you explain the population studies? Because I'm sure everybody out there in the real world is cooking them.
Yeah, so we have to figure that out. We have to do more work to figure that out. But it turns out that, for example, if you give people antibiotics and you give them, let's say, Indo-3-carbinol, just as an example, they really don't produce any DIM. If you give people who haven't had antibiotics, they do. And it turns out that the gut microflora is also important in converting these inert glucosinolates into active compounds. And again, we don't collect poop just yet, but we probably should to figure out what's going on there. And then, you know, there's actually ways to replace the myrosinase in vegetables. So another group, they'll actually take some Japanese radish, which has myrosinase, mix it up with the vegetable, which has been cooked, or I think they steamed it in their studies, and then you can actually have exogenous myrosinase that way. So presumably some people are getting exogenous myrosinase that's persisting. through the process of digestion. So it's really complicated. I didn't get into it, but it's really complicated.
Other questions?
Is it supposed to light up?
Yes. Push it up. You got it.
I was curious about, so the GSTT1, the genotypes that you were looking at, look like it's fairly common in terms of like you only had a few subjects, but a number of them were null for those. How common is that?
I think that's just a fluke because of the small number. So I think it's, what is it, like a little less than 20% are double nulls, something like that.
And has that been shown to have effects on metabolism? In
Yeah.
terms of, okay.
Carcinogens, isothiocyanase, yep.
Any other questions? I have one question. So you're looking all at the impact on metabolism of tobacco carcinogens, and I guess I was wondering if in your plans of the future, since they would presumably work on people who already have tumors and reducing, have you given any, in reducing or then lowering cancer risk after they quit smoking, have you given any thought to setting up some kind of study that would allow you to assess, in former smokers, for example, if you could have some impact on their subsequent cancer risk? Because in the mouse studies, it seems if you can give after chemical exposure, you also have an effect.
So that's definitely something that we have to do. I would say it's not something that I'll do in the next year, probably. But yeah, for sure. The trouble is, it's hard to figure out who to study. I think that's the hardest part.
Okay. No other questions? Oh, there's
one
another
more.
question.
So it turns out the tobacco research programs is really good at recruiting people. In reality, there's actually a relatively small, but a pool of people who do a lot of their studies, and so we get some people from that pool. These were all healthy people, so it wasn't difficult to find at all. We put out Craigslist ads, and now there's Study Finder, and we ask our friends. We get college students across the street because we actually compensate people. You can't do this for free, it turns out. And so college kids are poor.
How much would you pay me to eat raw Brussels sprouts?
So it's actually a lot of money. So to do this study that I just the last study that I described, I can't remember exactly, but it's pretty close to $500.
Wow.
Yeah.
Take my name. Anybody else today? Comments or questions? Thanks very much.
Thank you.